With this, we are moving towards our very last session. Diabetes is a threatening lifestyle disorder is associated with large variety of bone and rheumatic disorder. We have a renowned medical consultant with us, Dr. Arghya Chattapadhyay, one of the famous consultant rheumatologists. He will be the speaker for the next session. And as a chairperson, we have none other than Dr. Nishit Ranjan Chaudhuri, Senior Most Sports Medicine Consultant. We are blessed to have you, sir. I would like to request, sir, to please be seated and welcome our speaker.
Hello. Now we have come towards the end of the 2-day session discussing everything about diabetes, starting from the external aspect like obesity. We have dissected everything, the cardiomyopathy, the retinopathy, the nephropathy, and all other things. So we have dissected the human body. Everything has been extracted. Now all the bare bone is left. So at the end, we'll discuss diabetes and bone and rheumatic disorders in diabetes. The speaker is Dr. Arghya Chattapadhyay, and he's a famous rheumatologist, and he's highlighting on the bone and rheumatic disorders in diabetes.
Very good afternoon, everyone. Thank you, Chairperson Sir, for your kind introduction. And at the outset, I would extend my sincere thanks to the organizer for giving me this opportunity. So today I will be talking on bone and rheumatic disease in diabetes mellitus. If we look into the diabetes, it can be contributed to the bone and joint problem by two ways, by the disease per se or by the drugs which has been used for the diabetes management. So adhesive capsulitis is one of the commonest things that we encounter in our day-to-day practice with patients with diabetes. It's like any patient who is suffering from a long-standing diabetes having a shoulder pain. It's like an KBC type of lock kiya jaye, apna to frozen shoulder hoyeche. So if we look into the detail of the frozen shoulder or adhesive capsulitis, it usually unilateral shoulder pain which more than 3 months persist, and the reduction of the range of motions in all plane by 50%. It's painful and stiff shoulder if we look into the epidemiology. So it is around 1/4 of the diabetic patient compared to the 5% of only non-diabetic population having this kind of painful or stiff shoulder symptoms. And typical frozen shoulder kind of thing is 4% vis-a-vis 1% in normal population. If we look into the treatments, physical therapy is one of the most important aspects of the treatment for the adhesive capsulitis. Definitely NSAIDs has a very important role. Intra-articular steroids has a good study evidence that patient responds very well, or at least to the pain VAS overall. Whereas oral steroid, there are 4 major randomized control trials which has not shown any significant difference in the pain or overall outcome with oral steroid in patients with frozen shoulder. Sodium hyaluronate intra-articular injection has shown some benefit, suprascapular nerve blocks, and hydrodilatation by intra-articular using NS with steroid has shown some good impressive results in different studies. Surgical is the last resort of treating in patients with frozen shoulder. But is it something always a pain in the shoulder with a diabetic elderly population is a frozen shoulder. Let's go through the case. This 56-year-old male who is known diabetic for the last 10 years, complaining of pain and range of motion restricted in the bilateral shoulder. He also have a neck and lower back pain. So the consulted physician gone for an X-ray. There is cervical spondylitis. There is a lumbar spondylitis. So it was diagnosed as a frozen shoulder with cervical and lumbar spondylitis. And he was treated with NSAID physical therapy, but no improvement. Rather, it was a progressive disease. Patient was almost bedbound. Are we missing something, or do we need to know something else other than what we actually know? So actually, we need more detail about the pain symptom. So every pain around the shoulder in an elderly population, especially in a background of diabetes, may not be a frozen shoulder. It might be an inflammatory pain, which typically gives the history of early morning stiffness. Pain improves on activity and increases on rest. So this typical inflammatory history is very important. So it is very important to ask each and every person having a shoulder pain, elderly person, and also look for basic investigation like other inflammatory markers in elderly population, because there is a disease specific for at this age, which is known as polymyalgia rheumatica, which can absolutely mimic like frozen shoulder kind of presentation. So what is actually polymyalgia rheumatica? It's a pain and stiffness in the bilateral shoulder and upper arms, seen in almost all patients, bilateral hip and thigh pain, and almost 70%, and neck pain in 50% of cases. So what we misinterpret often by doing an X-ray, that patient must be having spondylitis, that's why she is having a neck or back pain along with shoulder in a background of diabetes is a frozen shoulder. But if we combine the dots or connect the dots of inflammatory kind of neck and back pain with a shoulder involvement, that too also an inflammatory nature, it could be an polymyalgia rheumatica, and which is highly treatable with disease-modifying anti-rheumatic drugs or steroids. These are the proposed European Society criteria for polymyalgia rheumatica, which requires an age more than 50 years, bilateral shoulder pain, and abnormal erythrocyte ESR or CRP level, and along with other symptoms of inflammatory arthritis, like which morning stiffness, more than 45 minutes, and other range of motion restriction in the hip joints and shoulder joints. And there are some ultrasound criteria for that is available in some of the centers in Kolkata. So from the next time, if any elderly patients having shoulder and neck pain, please ask for a morning stiffness and check for the ESR CRP. That could be, because it is highly underdiagnosed. There is a time when we had an idea that in Indian, we don't have polymyalgia rheumatica. But I have at least 15 cases as of now who was initially diagnosed as cervical spondylitis and frozen shoulder, who are actually in case of polymyalgia rheumatica, and they are highly treatable with different kind of disease-modifying agents. So every shoulder pain in elderly is not a frozen shoulder. Coming to the next, limited joint mobility, which is a very classical sign called prayer sign in a setting of diabetes. If you look into the epidemiology, it's seen approximately 25 to 50% of cases depending on different disease studies. It's male equals to female. So patients on insulin, juvenile onset, longer duration of the diabetes, these are all risk factors for having prayer sign. 3 to 4-fold higher risk of microvascular and 3 to 4-fold higher risk of macrovascular complication, those who are having this kind of prayer sign. So it could be another predicting marker or tool for underlying macro and microvascular diseases. There are 4 different stages, though this is not very clinically important, but definitely with time, if the vasculopathy increases, there are more severe disease and there are more severe limitations of the joint movements, and there is more deformity over time. If we move into the next or third entity called deepen contracture or stenosing tenosynovitis, again prevalence in different studies ranging from 0.6 to 31%, and hyperglycemia and fibrosis have been associated with TGF-beta activation. So these are one of the fibrotic markers which are responsible for this kind of contractures and or tenosynovitis. And if we look into the overall prevalence of deepen contracture, with age, like diabetes, the dotted line is the diabetic patients. Diabetic patients throughout age, they are more prone to having this kind of dupuytren's or stenosing tenosynovitis. And it's mostly the type 2 diabetes which has higher prevalence of all diabetic. Type 2 diabetes is the major contributor for this kind of disease. There are some interesting literature came 3 years back in Nature Review Rheumatology. JAK is the current hot topic in market. So this is one of the molecules which can block different kind of fibrotic pathways. So there are some conceptualization that whether JAK inhibitors can play an important role in treating all these patients. Still, we are waiting for the more robust data. But in theoretical perspective, there are possibilities that JAK will help in, to some extent at least, because it could decrease the STAT signaling in all 3 cell types inhibited fibroproliferative effect and interferon and interleukin 13, which are responsible for fibrosis. If we go through the next entity like carpal tunnel, which is a very common thing, many a time what we, in our experience, carpal tunnel syndrome often misdiagnosed as rheumatoid because patients sometimes cannot differentiate between a carpal tunnel syndrome from a joint pain or swelling or stiffness. Due to the numbness, patient often complain, ডাক্তারবাবু আমার হাতগুলো মোটা মোটা জয়েন্টগুলো ফুলে আছে যদি জিজ্ঞেস করা হয় do you having any joint swelling? Well, yes, I have joint swelling. I feel these are swollen. Because of the numbness, they feel swollen fingers and joints, but that is actually not the fact. That is due to the underlying carpal tunnel syndrome. So whenever you are diagnosing a case of rheumatoid, check for these symptoms or these are other differential diagnoses which are known as periarthritis, that symptoms originating from other than the joint per se. So again, the prevalence wise, it is more in type 1 diabetes and female. These group of patients are more prone to having carpal tunnel syndrome. Calcific tendinitis is another entity, again 30 to 50 years, rare, those with 70, more than 70, twice as likely occurs in women as men, more common in right shoulder, more common site occurs 1.5 to 2 centimeters. These are all more theoretical things like shoulder, right shoulder in a setting of the diabetes, unilateral acute pain. So it could be of 3 types, acute, subacute, and chronic. And based on the underlying etiology, it could be idiopathic or due to the underlying some kind of endocrinopathy, especially diabetes. So calcific tendinitis is some of the acute episodes, acute events one of the diabetes patient can present with. Let's go through our second case of back pain with HLA-B27 positivity. This 56 years male, this is a live case referred. I got a referral, 56-year-old male who is diabetic for last 10 years, presented with back pain in the last 4 months. And as a part of back pain evaluation, the X-ray was done and HLA-B27 was turned out to be positive. He was diagnosed as ankylosing spondylitis treated with NSAID, but absolutely no response. One must be very aware of patient treating with ankylosing spondylitis with NSAIDs. If there is a no response to NSAID, one should question the primary diagnosis of ankylosing spondylitis. Second thing, ankylosing spondylitis is very unusual to present for the first time at the age of 56 years. So these group of patients has a very typical inflammatory low back pain. Again, history is the most important thing that usually starts at or before 40 years of age. So anyone having classical low back pain which aggravates during the early morning, which feels patient that difficult in turning bed during the night, which improves on activity or improves on waking up, and after moving, that is a very classical history of inflammatory low back pain. Once and only patients having a classical symptom of inflammatory low back pain, then only the importance of HLA-B27 comes. Otherwise, HLA-B27 per se doesn't mean ankylosing spondylitis. This X-ray is a very classical X-ray of a disease known as, if again we look into the SI joint, the SI joint you can appreciate very clear bilateral SI joint of this patient, and it was a case of dish. If we look into the data of ankylosing spondylitis and B27 positivity, like only 63% of monozygotic twin having concurrence of ankylosing spondylitis, whereas dizygotic drastically reduced to 12.5%, which means it is not a monogenic disease. What we have a perception that is a genetic disease caused by HLA-B27 positivity. So there are other factors which are environmental factors and non-HLA genes which are responsible for the development of ankylosing spondylitis. So HLA-B27 just positivity doesn't mean patient is suffering from ankylosing spondylitis. So if you look into the data of DISH, it's more male dominant, and if you look into the severity, the graph shows at different ages the different mild, moderate, and severe disease at different ages. And more importantly, DISH is something that can affect each and every portion of your bony joints, or like this calcaneal spar could be a presentation of DISH, this kind of patellar projection, and also DISH can involve your hand joints in a different manner. So again, another point, especially for the calcaneal spar, this is not the cause of ankle pain. This is the effect of the ankle pain. So someone having Dr. Babu hard bereche godalite tar jonno byatha hocche. This is not the cause behind the pain. This is the effect behind the pain. This is due to the enthesitis or enthesial inflammation. That's why patient feel pain due to the enthesitis, not due to the projection. That projection cannot produce any pain directly by compressing the soft tissue. If you look into the management of the DISH, most of the time if it is asymptomatic, encourage exercise and ideal body weight. So more diabetes control, and especially like facial arthritis, spinal stenosis, dysphagia, there are some surgical excision required in case of spinal stenosis, and treat vigorously the underlying associated conditions like hypertension, diabetes, dyslipidemia, and gout. Moving to the next entity is Charcot's arthropathy. It's in a setting of diabetes is mostly unilateral foot involvement, and diabetes has a more predilection for mid-tarsal, metatarsophalangeal, and tarsometatarsal joints compared to these are the other diseases which are associated with Charcot's arthropathy, and they have more predilection for other joints. So this joint involvement or pattern of joint involvement also may be helpful in predicting the underlying etiology. Treatment-wise, it's more weight reduction, and bisphosphonate has shown some important benefits in a subset of patients with Charcot's arthropathy. Muscle infarction is the next entity, which is relatively rare entity, and distribution-wise is most commonly in the thigh muscles, and 55%, and these are the other areas where diabetic patient can present with muscle infarcts. And interestingly, NSAIDs therapy with NSAIDs has shown the lowest recurrence rate. So if you're suspecting and it is permissible with the diabetes and underlying kidney condition, NSAID therapy has the chances of lowest recurrence with muscle infarct. The next entity is stiff person syndromes. It's a relatively rare entity in association with type 1 diabetes because they both share the anti-GAD antibody, and that cause that is relatively rare and uncommon autoimmune mediated condition characterized with a painful episodic spasm and progressive muscle rigidity. So any diabetic patients, type 1 diabetes, having this kind of symptoms, one should keep in differential for stiff person syndrome. Osteoporosis, few interesting data on osteoporosis, like diabetic patients are more prone to having osteoporosis. If you look into the data for last decades, there are progressive increase in the bone mass. There is more and more populations with diabetic are becoming osteoporotic with time. So whenever you are looking into the diabetic patient, you should start screening for osteoporosis so that you can, because there are therapies which are available for preventing fractures or preventing osteoporosis or preventing progression of the osteoporosis. So because otherwise it will add on morbidity to the patients along with other diabetic hypertension, cardiovascular disease. So any fracture in a setting of diabetic elderly may be very detrimental or may be life-threatening in times. Looking into my third case, the 62 years old lady, She is diabetic, hypertensive, complaining of low back pain, 3 episodes when she became almost bedbound. X-ray spine, extensive degenerative changes with fracture in the vertebrae. Treated with for osteoporosis, like she was initially on bisphosphonates, then given teriparatide, but absolutely no much improvement. There is mild improvement in the back pain, but in times she had an acute episode. So what could be the possibility in this setting? Anyone, any guess? Let's show you. Definitely differential would be secondary is one of them. But I am going to show you some interesting pictures. These are the urate crystal deposit. This is a dual energy CT scan. These green dots are urate crystal deposited in the vertebral end plate, and that caused acute flare of pain. Again, history was the clue for doing the dual energy CT spine for this patient. She had a very typical history of acute inflammatory low back pain. Whenever she keeps telling, I have episodes of back pain when I got almost bedbound. I cannot move, I require higher dose of NSAIDs. So there was typical episodes of gouty flare kind of episodes. And after 5-7 days, I become absolutely normal. So that was the clue for my advising dual energy CT for this patient. Otherwise, there is no way of documenting whether there is urate deposits in the spine. And you can appreciate the urate crystal deposit in the vertebral end plate. These are no podagra there, no podagra. Her uric acid was high, but for the back pain, she was so much bothered why there was recurrent back pain. She was gone through MRI. There was some vertebral fractures, some edemas were there. In between, she was also treated for tuberculosis due to some edema. But she didn't tolerate, fortunately, ATD, and she stopped of her own. And she was so much bothered, like the acute episodes, she cannot do anything. So that's why we thought for, and she had an uric acid of 13, but it got deposited in the vertebral end plate. It was not thought of. Hemochromatosis is one of the relatively rare disease. So this is typically it involves the second and third MCP joints, and this is called iron fist sign. Due to the involvement of the MCP joint, the person cannot fist properly. You can appreciate there is a proper fisting. This is a normal person, and this is the hemochromatosis person. Though small joint pain and back pain is one of the major one of the common thing, but large joint involvement is in hemochromatosis, which cause the major morbidities in a patients with hemochromatosis. So this is due to just diabetic connection. That's why I feel to mention it. Drugs, definitely these are drugs which are commonly used in diabetes, and they have some risk of different kind of myalgias and arthralgias. But I can remember 3-4 cases of patients with sitagliptins having very severe arthralgia, almost mimicking rheumatoid. They are negative for all markers, and inflammatory markers was also normal or just above the normal. Just stopping the drug was the therapy. Nothing else is required. So if your patients developed typical polyarthralgia kind of thing after starting gliptins, one should keep on differential of drug-induced arthralgia in those group of patients. My last case, though this is not something related to diabetes, but some of the endocrine disease. This 32-year-old female presented with bilateral hand pain in the bilateral hand, generalized body ache and weakness, pallor and shortness of breath. There is anemia, pericardial effusion, ANA was 1:80 positive. So we are just tempted to starting steroid because we made a diagnosis of lupus. Is it actually a lupus? Can I classify this patient as a lupus? Well, international standard is 1:80. In our practice, based on some study done in SGPJ Lucknow, we do in 1:100 as in baseline screening data. higher the ANA titer positivity, there is higher chances of having underlying connective tissue disease. So like in this case, there is incomplete information. I don't know other organ system involvement, so no information regarding other specific antibodies, complements, urine, so we don't know other things. So we cannot tell this patient having a, so, and what does this mean? So clinical and diagnostic value of ANA titer 1:80, the likelihood ratio is 0.5 compared to the 1:640, that's likelihood is 19. That you all are telling that this is a relatively lower titer. In higher titer positivity, there are higher chances of or higher likelihood of having underlying connective tissue disease. But 1:80 is not a bar as per the latest criteria. The screening titer is 1:80 for ANA by HEP2. So this is the latest criteria, 2019 ACR regular criteria, where ANA positivity is an entry criteria. So if we want to classify someone into lupus, you need to have an ANA positivity, otherwise you cannot classify them as a lupus. So after that, you need to have this clinical criteria and this laboratory criteria, and you need to make a point of 10 to call or classify someone as lupus. So in this patient, we cannot classify this patient just based on the information available, or patient actually don't had anything else, just an ANA positivity in pericardial effusion and polyarthralgia. So once we checked for an thyroid, she was grossly hypothyroid, and hypothyroid is a condition where ANA can be false positive. So pericardial effusion can be explained by the hypothyroid, polyarthralgia can be explained by the hypothyroid. So it was basically in case of hypothyroid. So every positive ANA is not equals to lupus. Thank you.
Thank you, Dr. Arghya Chattapadhyay, for the elaborate discussion on the diabetes and the bone and joint disorders. Now, one thing you have mentioned regarding the frozen shoulder. Actually, most of us during our life period, we have suffered from shoulder pain. And commonly, it was diagnosed as frozen shoulder. But you have mentioned that it is not always the frozen shoulder. Can you highlight on this? Because it is a very important
So
area.
like, this is an entity called polymyalgia rheumatica, which occurs in elderly. It's a disease of elderly of, we call more than 50. We have seen patient less than 50, but it is unusual to have an initial presentation of polymyalgia rheumatica below 50 years. They typically have inflammatory shoulder pain and inflammatory neck and back pain. They typically complain of shoulder, neck and back pain, which maximal intensity during the early morning when they get up from the bed. There is a difficulty in turning bed for the back pain and neck pain. And the neck pain and back pain disappears or goes away with the progression of the day when he or she started doing activity. So there is a typical history of inflammatory nature of pain involving the neck, back and shoulder area. It's usually bilateral shoulder involvement compared to the unilateral shoulder involvement in case of frozen shoulder. So history is the most important clue, and another next step will be if someone having a shoulder or back pain, neck pain, if there is a history suggestive of inflammatory nature of neck or back pain, then next step will be ordering one ESR CRP, very simple test. What we often do or what we often seen, many of these patients are already, because CBC we often do, and there is a raised ESR and CRP, and we try to ignore because we cannot explain that. ঠিক আছে আপনার ওই তো বয়স বাড়লে একটু ESR বাড়বে. So that is the usual explanation কি তো ঠিক আছে ওইটুকু ESR কোনো সমস্যা করবে না. But that ESR is the important clue if someone having very typical inflammatory pain and a raised ESR, that should be an important clue for polymyalgia rheumatica. And next, it can be just a clinical diagnosis because nothing else, no antibody, nothing else is there. Next, ultrasound can be very helpful for that. Joint ultrasound, we can look for subacromion bursitis. There are typical markers for both hip and shoulder girdle for polymyalgia rheumatica screening.
I think another 2 points must be kept in mind. the rotator cuff tendinopathy. Diabetic patients, they are mostly inactive most of the days. And we also we also advise for the exercise. But the diabetic patient, if they are not active properly, the rotator cuff loses its capacity and the muscle strength. And in that case, there is some shoulder pain. And also, due to this inactivity of the rotator cuff, any component of the four muscles of the rotator cuff, if they are inactive, the humerus hinges below the scapula. So that causes a pain, and that also restrictive pain. And this is very confusing with this the frozen shoulder. So this should be kept in mind that not always all the shoulder pains are you have rightly pointed out that. And
I have one comment regarding polymyalgia rheumatica.
Sir.
It occurs in above 50 years. It is associated in 15% of cases with giant cell arteritis, which requires high dose of steroids, lest the patient loses vision. And that is a point worth remembering, number one. Number two, regarding carpal tunnel syndrome. A clinical pointer towards carpal tunnel syndrome is that it occurs more at night or during period of rest. Whereas inflammatory arthritis, you have rightly said, it occurs early in the morning. And in carpal tunnel syndrome, the typical history is that shaking the hand or raising it above shoulder relieves the pain. And third point that I would like to mention is that rheumatoid arthritis has also some association with type 1 diabetes.
Both type 1 and type 2. Both. So like that point is very important for giant cell. I purposefully did not tell anything on giant cell. Like for any polymyalgia, if you are suspecting or if you have diagnosed any patients with polymyalgia rheumatica, and if he or she is not responding to 15 milligram of prednisolone, that is usually the test dose what we give. Like it's melt like anything. Like you give a 15 milligram prednisolone, the next day patient will come and apnake bhagavan bola jabe. It's like that drastic response. If patient is not responding to up to 15 milligram of prednisolone, you should question two things: whether you are dealing with an polymyalgia rheumatica. Second, whether there is an underlying giant cell arteritis. Because giant cell arteritis do not respond that low dose steroid. So they require higher doses of steroid. So what we do usually whenever we go for an ultrasound for polymyalgia, we also check for the underlying subclavian and carotid thing. Mostly subclavian thickening, there are some scoring and criterias. We have also proposed one scoring system for this giant cell arteritis. There are two variants in India. There again, there is an lack of possibly, we think we don't get that much of giant cell arteritis. And we had a special variant of giant cell arteritis, which is large vessel giant cell arteritis, which mostly involve the larger vessel. And they have another kind of presentation, like elderly with fever of unknown origin. That is a presentation of giant cell arteritis with large vessel involvement. Nothing else. No typical giant cell kind of presentation like headache, jaw claudication, what we have been taught for the years, that giant cell will present like this. But in our setting, due to some HLA association, like we have more TACA issue than Western population, like that we have some giant cell arteritis which has a more predilection for large vessel involvement and who presents only with fever, nothing else, recurrent fever. You will get nothing else in any investigation other than a raised ESS-CRP. Just do a PET scan, otherwise you cannot document unless your radiologist is very much conversant with looking for the giant cell in CT scan. It is seen in CT scan also, but PET is the more definite thing that you can tell, yes, there is inflammation in the blood vessel, and that is the presentation of that group.
In general practice, sir, we very commonly come across knee osteoarthritis. And pioglitazone is an anti-diabetic drug which has the very robust insulin sensitizing action. And we frequently use that. But if a patient comes with knee osteoarthritis, maybe early, maybe moderate, in my practice, I tend to discontinue the use of pioglitazone. What is your opinion on this point?
Practically for osteoarthritis, there is hardly any evidence of any medicine is working.
No, I discontinue. Whether
For
continue or discontinue the glitazone.
Glitazones. No, we don't discontinue anything like if it. Osteoporosis actually, there are 2-3 drugs which can cause osteoporosis, but like it is, I personally don't see any diabetes patient. So I give it to the physician or endocrinologist. If they feel the glitazone is required for that patient absolutely, then it's fine. We need to plan our medicine accordingly. But definitely these are drugs which can cause more osteoporosis, but there are therapies for osteoporosis also.
How common is HLA-B27 positivity in our country? And how common is ankylosing spondylitis?
Like the data is like in 95% of HLA-B27 positivity will have ankylosing spondylitis. Normal population, again, 3 to 5% of normal population carries HLA-B27, but they never had any ankylosing spondylitis.
So out of 3 to 5%, 0.1 to 0.2% is having ankylosing spondylitis.
No, like 3% or 3 to 5% of normal population carries B27, but they never had a symptom of B27, like ankylosing spondylitis. So we don't advocate to testing for family testing for B27 unless until they are having any symptoms. So no point of it. It just increase your anxiety, nothing else.
Thank you.
Dr. Chattapadhyay, actually, in most of the cases in rheumatology and the joint pain, we use the short-acting or long-acting steroids. Specifically in the diabetic patients, what is your opinion of use these steroids?
So like for arthritis, these days we hardly require any steroids. Mostly, if at all we require for a very short course because with the availability of the DMARDs and the effective DMARDs, we hardly require these days long-term steroid. So for short-term, we explain to the patient I mostly prefer intramuscular triamcinolone because patient cannot take off his or her own. Otherwise, once you put patient on oral steroid, it is such effective thing, patient will be more addicted to steroid because it is cheaper, it is more effective than any DMARDs for a short-term thing. So I do prefer to use intramuscular steroids for those patients. And I explain to them and I ask them to visit to their physician who is treating the diabetes, because for the time being they may require higher doses of dose adjustment for the. But disease like lupus and some other disease where we actually require for a long-term steroid, then we need to discuss with the physician for like proper planning, because we had a plan for how long we will continue the steroid. So for every rheumatological disease, we are moving from the concept of steroid to low steroid and over time possibly no steroid.
Thank you. Any question from the floor? Thank you. Hey, Mike, please.
So sometime we encountered a patient presents with the non-inflammatory heel pain, and we do X-ray of ankle joint and found that heel spur is present, and we advise shoe. What are the other possibility and how can we approach it?
So like this is an enthesitis. Whatever may be the underlying disease, this is enthesitis of your ankle joint. So it may be at the insertion of the tendo Achilles, it may be at the plantar fascia insertion. So now you need to find for the underlying causes of enthesitis. Like young male, you should look for an spondyloarthropathy group of disease. Even we have seen patients with uric acid, only urate crystal get deposited at that enthesial point. Dual NG-CT can help you in diagnosing that. Otherwise, you cannot get from any other investigation. So urate crystal deposited and we started colchicine, it's like gun. So it is an underlying enthesitis. Spondyloarthropathy group of disease, especially psoriatic to start with, can present only with enthesitis. Enteropathic, like IBD underlying, patient can only present to start with only enthesitis. There are some group, though rare, but they present only with enthesial pain, nothing else. And urate crystals deposition at that site of enthesis could be an important differential for your cases.
USG may be done.
Sorry?
USG.
USG is not going to help in those cases. By USG, you can document the enthesitis. You can see the enthesial changes, the edema at the site of enthesis, but you cannot get the underlying diagnosis, etiology you cannot get. Like if you are suspecting a urate crystal, then go for a duolingeicity of that area, like ankle joint, to whether there is any urate crystal deposited there or not. Otherwise, if patient is not affording for, or if it is not available at your site, then you can give a colchicine trial that works fantastic, like urate crystal deposit enthesitis due to.
Uric acid may be normal.
Uric acid may be normal in those cases. Uric acid, two important points regarding uric acid. You should not test uric acid at that height of pain of uric acid if it is very classical. In that time, you can, majority of the time, you can get a normal uric acid. Because at that point of time, the urate crystal got deposited to the joint or wherever the site there is a pain from the blood. So blood level may be low or normal, even low. So it's always better once the acute pain subsided, because acute pain management is same for everything. So then once it is subsided, then you check for the uric acid. That will give you a more better idea. And in cases of tendon, like ligaments or tendon deposition of urate crystals, in my experience, majority of the patient were at the normal range of uric acid, majority of the patient, or just higher normal like 8.99 max. But we usually don't start treatment for those patients.
If the patient is on atorvastatin, then can we start colchicine?
Yes, yes. No problem.
Or
it's not that harmful.
Okay.
Some patients develop muscle problem. So if there is any muscle problem, then you can plan to
stop.
If we
suspect psoriatic arthritis, then if there is no skin changes, then how can we confirm it?
Like you will need to take history, a family history for psoriatic. 10% of patient may even psoriatic rash developed after 10 years of joint symptom. So family history will be a very important thing.
Any diagnostic?
Sorry?
Any diagnostic clue or tools?
Diagnostic clue again for like family history of psoriasis, nail changes some patients can have. And other than that kind of typical asymmetric oligoarthritis, that will be an important clue for psoriatic.
Our last question, frozen shoulder, how can we confirm it?
Well, frozen shoulder is an entity like, this is like fever. We cannot confirm fever. Fever is a high temperature, is a fever. Like a frozen shoulder is that kind of thing. So you need to look for the underlying etiology, why there is a restriction and pain and inflammation in the movement of the joints. So frozen shoulder is a broad entity. So that may be even due to an underlying spondyloarthropathy. That may be a rheumatoid patient having, we've seen many rheumatoid, like one variant of rheumatoid called palindromic rheumatoid, where at a time single joint effects. It's typically like rheumatic fever. So one joint acute pain and inflammation. So when there is a shoulder joint involvement, isolated one shoulder joint involvement, Dr. Babu, amar to age frozen shoulder hoyechilo ekhon hater joint gulo byatha korche. That is not, frozen shoulder is not per se a diagnosis. You need to look for the underlying causes, what actually causing the inflammation and restriction of the movement of the joint.
Thank you. Thank you, Dr. Arghya Chattapadhyay, for the elaborate discussion and the interactions. Thank you all the audience.
Thank you, sir.
Now you hand over to the organizer.
Thank you, sir. It's time to facilitate our speaker. I would like to request our chairperson to please facilitate him.